I want to welcome you to our webinar on Social Determinants of Health Screening Tools 101 for health center staff serving public housing residents. Thank you for joining us today. And before we begin, I just want to go through some quick housekeeping items in case you're new to the Zoom platform. Our participants are muted right now, but you're more than welcome to engage through the chat. During this webinar, we will be conducting a few poll questions and a Q&A session at the end of the presentation, where you will have the option to participate. If you'd like to participate verbally during the Q&A session, please raise your hand and your line will be unmuted. This webinar is also being recorded, and the slides and recording link will be sent via email and posted to our website within a week after today's session. Next slide. So just a little bit about the speakers for today. My name is Frida Pineda Sandoval, and I am the research assistant here at NCHPH. And today I will be moderating the webinar. Today we also have the honor to have Saki Malik-Cho, who is our Director of Research, Policy, and Health Promotion, and she will be presenting to you all the information about the social determinants of health screening tools. Next slide. And in case you're not familiar, the National Center for Health in Public Housing aims to strengthen the capacity of federally funded public housing primary care health centers and other health center programs. NCHPH provides training and technical assistance, research and evaluation, outreach and collaboration to health centers that are located in or immediately accessible to public housing. Per UDS 2020 data, there are 435 health centers in or immediately accessible to public housing that provide healthcare services to 5.1 million patients, and 107 health centers that receive PHPC funding that provide services to more than 866,000 patients. You can also visit us at nchph.org to learn more about our webinars, learning collaboratives, interactive maps, and publications. This webinar is supported by the Health Resources and Services Administration of the U.S. Department of Health and Human Services as part of an award totaling $684,000 with 0% financed with non-governmental sources. The contents are those of the authors and do not necessarily represent the official views nor an endorsement by HRSA, HHS, or the U.S. government For more information, please visit hrsa.gov. Okay, and without further ado, I'm going to pass it on to Saki.
Hi, so thank you so much for joining us today. We just wanted to show a little bit of information about you. We have around 20 folks here participating today. 4 from New Jersey. We know there's a group of folks from Sioux Falls Health Center, so welcome. We're very excited to have you here and learning with us, and as well as just across the United States and even Canada, someone from Canada. So welcome, thanks for joining us. In the registration survey, you all mentioned a couple of things that you would like to, a couple of challenges and strategies and things that you would like to get out of the webinar today. Some of the challenges that you mentioned for screening were insufficient time and challenges with coordination. Some of the strategies that you mentioned were, having ongoing communication and using a shorter tool. And some of the things that you would like to get out of today's webinar include learning about SDOH screening tools and more education and resources. So we take a look at this registration data, and I really appreciate you filling out this survey, and hopefully we will address some of the challenges and definitely give you more education and resources about screening. So thank you for that. So screening for the social determinants of health, or SDOH, can be a long and windy journey for health centers. There are many steps to developing and implementing a screening process, and many steps along that journey. So just for the purposes of today's webinar, we are providing a Screening Tools 101 for health centers serving public housing residents. It's to provide some basic background and introduction to developing a standardized approach to screening for SDOH. So to do that, we're going to start by level setting. Our first stop here is to define what we mean by the social determinants of health, why it's important to screen for these social risk factors, particularly for public housing residents. Our second stop will then to talk about all of the domains that could be included in a screening tool and which ones might be the most important to your patient population. Our third stop will be discussing some of the most common screening tools that are available and how they differ from one another. And then our fourth stop will be to discuss a set of criteria on how to prioritize and choose which tool might be right for you. And then our final stop, we're going to look at an example from the state of North Carolina and the basic steps that they took to develop their screening protocol. And we hope that this example might spark some ideas for you all to consider in your planning. There are many more steps to consider after you choose a tool, but for today, we're going to focus on those 5 things and then point you to where you can go to get additional resources for the rest of that journey. The reason why we've decided to provide this type of 101 training is, according to the most recent data from UDS, or the Uniform Data System, which all health centers are required to report to HRSA, we know that around 24% of public housing primary care health centers have not yet started to collect data on individual patients' social risk factors outside of the data that's reportable in the UDS, but they are in the planning stages. And we know that most health centers have been incredibly busy with COVID-related needs for the past couple of years. So we're hoping that this training will be helpful and utilized by health center staff that have had to put screening to the side, but are now ready to pick it back up again. So our first stop is to go over why we might screen for SDOH. So again, we're just going to start with some level setting and defining SDOH. The social determinants of health are conditions that impact our health and well-being because where we live, work, learn, and play impact our health more than the medical care we receive. The Healthy People 2020 or 2030 definition is that health starts in our homes, in our schools, in our workplaces, in our neighborhoods, and in our communities. And we know that taking care of ourselves by eating well, staying active, not smoking, getting all of our immunizations, and seeing a doctor when we're sick all influence our health. But our health is also determined in part by access to social and economic opportunities and the resources and the supports that are available in our homes and in our neighborhoods and communities. Also, the quality of our schooling and the safety of our workplaces, as well as the nature of our social interactions and relationships. So these conditions in which we live explain in part why some Americans are healthier than others and why some are not as healthy as they could be. We at the National Center are particularly interested about individuals that live in public housing and then the health centers that serve those populations. According to US Department of Housing and Urban Development, or HUD, there were roughly 1.6 million public housing residents in 2020. Most households were low income, 36% had a member who was elderly, and 40% had a member who was disabled. Approximately a third were headed by single women with children. So this demographic data shows us that there are many vulnerable populations that are living in public housing. But both the combination of socioeconomic status of residents and then also the environments where they live can have a great impact on their health potential. This framework from the University of Wisconsin's County Health Rankings and Roadmaps shows us that 40% of health outcomes are driven by social and economic factors and 10% by our physical environment, which means that at least half of our health outcomes are a result of what we call SDOH. And we know that low-income communities where many public housing sites are located are more likely to have lower access to healthy foods, have unsafe and unhealthy housing, and be in neighborhoods that experience violence and racism. And for the first time, we have the data that show that SDOH is impacting the health of public housing residents. According to a joint report from CDC and HUD, adults that receive housing assistance from HUD have higher rates of chronic health conditions, mental health conditions, and are greater utilizers of healthcare than the general population. And as you're taking a look at this data on the slide, for all of the conditions that are listed, I just wanted to point out one thing here, and that's the different comparison groups. So you can see quite a large disparity between HUD-assisted adults, which is in the first column in the table, and then the general population, which is in the last column. But the column in the middle represents other low-income renters in the same income group that do not have housing assistance. And this data was also adjusted for other confounders like age and race and disability. And you can see that even though this group is experiencing the same level of poverty as those in HUD assistance, they are better off when it comes to health, which just shows you that SDOH is impacting the health of public housing residents. When you think about SDOH and that additional impact of SDOH on access to care, we find that SDOH can have up to 6 times the impact on health as compared to clinical care. And addressing SDOH requires collaboration across medical care, public health, and social service providers. Collecting data on a patient's SDOH in a standardized way can have multiple benefits across the spectrum of care. On an individual level, for patients and families, it can empower them to improve health and well-being by providing them with referrals and access to the services that they need in a holistic way. For care team members, it can give them the data that they need to better manage their patients and their populations. At the health center organizational level, it can provide the information needed to better design the care teams and the services to provide more patient-centered care. At the system level, it can integrate care through cross-sector partnerships. It can help develop prevention strategies and support advocacy efforts. The data can also support the development of value-based care payment models and incentivizing risk interventions. And at the broadest policy level, collecting SDOH data can ensure health systems have the capacity to serve complex patients. So now we're going to have our first polling question, and Fide is going to lead us through that poll.
Yep. So right now I'm going to launch the poll question, and if you guys can please provide your answers. You can answer more than one option. And the question is, why screen for SDOH? Would you screen because you want to get information on an individual level, organizational level, system or community level, payer or policy level? Okay. All right, so based on the results, we got 100% would like to screen because of SDO system or community level. Next, we have individual level, organizational level, and then at a policy level and at a payer level.
Thank you. This is really helpful for us to know what's most important for you all. So our next stop is what domains to screen. What items should we be capturing in a screening tool or an assessment? I would like to point you to 2 key resources that provide the scientific evidence on the relationship between SDOH and health outcomes and how to capture that data within patient electronic health records, or EHRs. In 2014, the Institute of Medicine engaged in a 2-phase study to identify domains and measures that capture SDOH to inform the development of recommendations for meaningful use of EHRs. In their first report, Capturing Social and Behavioral Domains in Electronic Health Records, it specifies criteria that should be used in deciding which domains should be included. It also identifies some core social and behavioral domains to be included in all EHRs and identifies domains that should be included for specific populations or settings that's defined by age or socioeconomic status, race and ethnicity, and disease or other characteristics. In the second phase of the report, they narrow down the domains to be included in the EHRs, but it also includes the implications of incorporating these into the EHRs. What are the challenges and how to overcome them, how to link EHRs to other organizations, and some case studies. So that second report would be very useful in the future for all of you as you kind of continue on that implementation journey. The committee decided on the following criteria for domains to be given a high priority for inclusion in EHRs. The first is the strength of the scientific evidence demonstrating that there's an association of the domain with health outcomes. The second is the usefulness of the domain for managing and treating a patient's illness or monitoring population health and making policy decisions that affect the patient population. The third is the availability of a reliable and valid measure of the domain. The fourth is feasibility. That's whether there's a burden that's placed on the patient, the clinician, and the administrative time and cost of interfaces and storage. The fifth is sensitivity. That's if the patient discomfort regarding revealing some of that personal information is high and there are increased legal or privacy risks. The sixth is accessibility of the data from another data source. So if there's information from an external source that might be accessible to meet the needs of patient care, if that were the case, then that domain would have less priority for inclusion in the EHR. So here are the domains that were identified, and this is quite a comprehensive list. There's socio-demographic domains, psychological domains, behavioral domains, individual level social relationship domains, and then also neighborhoods and communities. It's quite a comprehensive list. It's incredibly challenging to capture all of that in a single tool without just being very exhausting both to the patient and the staff. When we go through the example from North Carolina, you'll see how they prioritized which domains to include in their screening tool. But I just wanted to start off with the evidence base and the gold standards from the IOM. There's one subdomain that would fall under neighborhood and communities, which is not in the IOM report, but that I would like to highlight. It's a disparity that existed before the pandemic, but certainly came to the forefront of everyone's attention during COVID-19, and that's access to broadband internet. The latest data from County Health Rankings and Roadmaps shows that 19 million Americans lack access to broadband internet, and it's an issue that impacts both rural and urban households. 1 in 5 urban and 1 in 4 rural households don't have reliable internet. More than half of all counties experience internet speeds that are below the federal standard, and 65% of rural counties also have slow internet. I'm going to quote Marjorie Gibbons. She's the co-director of County Health Rankings and Roadmaps, and she says, broadband touches every part of life, from children being able to log on for remote classroom instruction, or adults being able to access vital telehealth services, to families being able to order groceries or prescriptions or apply for public assistance. The effects of digital access are so wide-ranging that it is intrinsically tied to the health of all communities. But even with access, there's another layer of complexity and inequity, and that's digital health literacy. Digital health literacy refers to the ability of an individual to seek, find, understand, and appraise health information from electronic sources. And these digital health tools can include mobile tracking apps, wearable devices that monitor health. It can include live video, telemedicine, or accessing online provider reviews and health information. But the use of digital health tools really varies greatly by geography and socioeconomic status. Low-income individuals are less likely to have adopted or utilized a digital health communication system to track or monitor or maintain their health. Elderly populations with low education are more likely to have lower levels of digital literacy. And then patients with low health literacy are also less likely to use health information technology tools. Disabled Americans are about 3 times as likely as those without a disability to say that they never go online. So all of this can exacerbate already existing inequities in care. So I'm asking you to consider this on top of the recommended IOM domains. But you can't obviously collect data on everything. So leads us to our next polling questions. What domains do you think are the most important for your patients? Sorry, Fide, go ahead and lead that poll.
Yep, I've already launched it.
Oh, good.
The options are, socio-demographic domains, psychological domains, behavioral domains, individual level, social relationships domains, or neighborhood and community domains. Okay. Keeps changing. Okay, I'm gonna close the poll. And it seems that the most common one is socio-demographic domains, followed by psychological, behavioral, and neighborhood and community domains. And lastly, we have individual level social relationships domains.
Okay, thank you for sharing that.
Yeah.
Okay, so next we are going to go over some of the most common screening tools used by health centers. Here are 2 more key resources. This is the Screening Technical Assistance and Resource Center, or the STAR Center, and the Social Interventions Research and Evaluation Network, or SIREN. These are robust websites with detailed information on all of the screening tools that are available. There are a lot to choose from, and you can look at them based on the domains that are included in the tool. So there's like a long checklist, and you can say, I'm interested in behavioral health domains, and click on that, and it'll list all of the screening tools that include that domain in them. According to UDS, public housing primary care health centers are using these standardized screeners for social risk factors. The most common screening tool is called PREPARE, which stands for Protocol for Responding to and Assessing Patients' Assets, Risks, and Experiences. The second most common is the Accountable Health Community Screening Tool, followed by the Recommended Social and Behavioral Domains for EHRs, We Care, which is a pediatric screening tool, and the Health Leads Screening Toolkit. Because it's so popular, I just want to share some information on the PREPARE tool, which was co-developed by the National Association of Community Health Centers, the Association of Asian Pacific Community Health Organizations, and the Oregon Primary Care Association. PREPARE is a national standardized patient risk assessment protocol. It's built into the EHR, and it's designed to engage patients in assessing and addressing SDOH. It's customizable, and it's designed to assess needs and also to respond to needs at the patient and the population level. For those of you who haven't seen the PREPARE assessment form yet, there are a total of 21 questions that assess for 16 core measures. And these are listed on the left-hand side of your screen. There's also optional measures on the right-hand side of your screen where you have the opportunity to assess for other social risk factors, such as a patient's refugee status, their level of safety, where they currently live. It's important to remember, as I said before, that the purpose of the screening tool is not to be duplicative. So outlined in this red box, income, insurance, housing status, etc., these are all mandatory UDS measures that are already collected by health centers, which really leaves health centers to collect just an additional 7 core measures. And those core measures might already be collected through other data sources. So as you're developing your customized screening tool, keep in mind all of the sources of data that you are collecting to minimize any duplication. You don't want to ask a patient a single question multiple times. Just an FYI for digital health literacy, there is only one validated scale. It's called the EHealth literacy scale. It's an 8-item scale designed to measure digital health literacy. Here are just some example questions to consider about access to the internet. What types of devices are being used to access the internet? What kind of internet plan are they using? How much data do they have? Are they sharing that data with multiple users? Where's internet access? And also their level of comfort in using patient portals or other digital communication. Another consideration is to take a look at the actual questions in the assessment for each domain. There's a lot of variability in the length of the question and the way that it's asked, whether it's a yes or no question, whether there are longer, more descriptive answer choices. But you can see here that there are many different approaches to just the housing insecurity domain. Some tools like the Accountable Health Communities tool and the Medicare Total Health Assessment and Prepare tool ask folks to describe their current living situation, and there are multiple options for describing certain scenarios like I have a steady place to live, or I don't have a steady place, and examples of what that might include. Other tools ask a more direct yes or no question, like, are you in a shelter? Are you living in Section 8? Some ask whether an individual has concerns or is worried about losing their housing, or if they're at risk for homelessness, which is different from where are you currently living. And some ask about whether they need help if they do say that they are worried. All of these questions have been validated. So it's more of a question of understanding what is being asked specifically and if that fits your needs, and if you need additional follow-up or not, and what that follow-up will include. Also, whether the wording fits in culturally with your patient population. Using terms like worried might resonate with some cultural groups and not others. So it's important to be cautious about how a tool might be perceived, how those questions might be perceived for certain cultural groups, and how that might contribute to health inequity, and whether or not that's intentional. So our fourth step is, you have all of these tools. How do you decide which tool to use? Here are some criteria to consider. So the first is the domains, making sure that the domains that are included in the tool cover the challenges that are faced by your patients. And in addition to that, overall length of the assessment, how many questions are in it, and will the length of the survey cause a burden on patients? Some of you all mentioned this in your challenges in the registration, that the tool is too lengthy. Sometimes you have to cut questions because you don't have enough time to ask them. The next is what is the reading level of the assessment? And this varies greatly. Sometimes the reading levels are at the 6th grade level, sometimes they're at the college level. So taking that into consideration. Is the language written appropriately for your patient mix? And is it available in other languages that represent the diversity of your patients? Is it free? Is there a cost associated? How easily can the tool be integrated into the EHR, and does that depend on which vendor you're using, if you're using Epic or NextGen? Is there any flexibility in the tool? Can you add or modify questions? And then what kind of resources are needed from an IT standpoint or a staff training standpoint in order to implement the tool, thinking about your workflows? And also whether the tool is validated and the ranking or the rating of that tool. So Kaiser Permanente and Siren worked together to develop a rating system for screening tools. You can access that information from that link that I provided in an earlier slide. Just to see how this criteria can be applied, here's an example of the Accountable Health Community Screening Tool that was created by Centers for Medicare and Medicaid Services. And they developed this to use in their AHC model. This is a unique tool in that it combines screening across 5 domains. into only 10 questions. And few social needs screening tools achieve that kind of brevity and breadth in one survey screening tool. It takes approximately 5 minutes to complete. The questions are at an 8th grade reading level, and it's available in multiple languages at no cost. The questions in the screening tool are meant to be used for individual respondents who answer the questions themselves. And there is also some flexibility and some supplemental domains to add if needed. There are many SDOH screening tools that are available to health centers, and it can be a real challenge to research, assess, and rank which ones are better suited for a specific health center's needs and capacity and patient population. So another key resource that we developed is this guide to screening tools, where we identified and described and compared a list of evidence-based screening tools that are commonly used at health centers using that criteria, and you can access it with this link. So our final stop is to look at an example of the steps an organization can take to developing an SDOH screening process. And I specifically wanted to share this example from the North Carolina Department of Health and Human Services when they adopted a standardized set of SDOH screening questions, because I think they did a really great job explaining their process. The link to their report is on this slide, and it's also a really good resource. Just some context for this: the state of North Carolina engaged in a complete system redesign when they transitioned their Medicaid and their health choice programs from fee-for-service to managed care. Their Medicaid beneficiaries would be enrolled in health plans that are responsible for care management, and the state included linking patients to programs and services that address SDOH as a component of the care management requirements. So this was a real opportunity for the state to provide guidance on a standardized screener to all of those teams. And they had some great guiding principles. First, the screening questions had to cover domains that were clearly linked to health outcomes. Second, the screening questions had to be simple, brief, applicable to most populations so that they could be easily integrated into the workflows and all of the diverse and varied settings across the state. The idea wasn't that it needed to be very comprehensive or exhaustive, but that a positive response might trigger a more in-depth assessment that allowed a greater understanding of the specific needs and more targeted navigation to resources by a community health worker or a care manager or a social worker or other member of the team. Third, the questions had to be validated, drawn from best practices, and be written in accessible reading levels. And then the fourth, to the greatest extent possible, the questions should align with existing screening tools like the Bright Futures questionnaire or Prepare or Accountable Health Communities. So they use these principles to kind of design their process. And that included, over the summer, they met with key stakeholders that were interested in SDOH or who were already working on SDOH to find out what they were studying and what they were collecting. They also did a literature review and examined some of the best practices related to screening and identifying SDOH. They reviewed screening tools, identified which priority SDOH domains that they wanted to include, and they decided to focus on food insecurity, housing stability, transportation, and interpersonal violence. And then they compiled a list of validated questions from various existing tools to create their own standardized screener. So they pulled different questions and created the screener that was important for their state. And then over the course of the winter, they convened an advisory group of diverse experts to review and refine the questions. And they did that over 4 sessions during the winter. So it's a long process to develop the screening tool and very thoughtful. This is their implementation process. Again, we're not going to go over this in detail. This would be like a next step after you developed your screening protocol. I wanted to include it in the slide deck though, just so you could see, what do you do with the tool once you have it? What kind of training you need to give to your staff, deciding, who should be the one to screen the tool, and what happens when a patient scores high on the tool. How do you send them to care management? How do you get them in touch with different community resources and making sure you translate it to other languages? I'm just going to keep this in this slide deck so you can refer to it later on. And again, the link to that full report is on the bottom of this slide. So that's all that we're going to discuss today. If you're interested in taking a deeper dive, I suggest that you also review the slides and the recordings for a learning collaborative that we hosted last year. We have several speakers and health centers that share their experience. You can also take a look at the second IOM report, which discusses implementation challenges and has those case studies that I mentioned. You can also go to the Health Center Resource Clearinghouse for all of your training and technical assistance needs. There's a wealth of information and resources available to you, many options for screening. And that's the end of my presentation. I think Fide is going to open it up for questions.
Yep. So now we're going to enter a Q&A session. If you would like to verbally ask a question, you can also do that by raising your hand and your line will be unmuted. Thank you so much, Saki. That was a very thorough presentation. Or if you'd also like to share some of the promising practices that you guys have been implementing, you can also do that through the chat. Okay, so in the meantime, while we wait for any questions to come in, I'd like to remind everybody that at the end of this webinar, we have a post-evaluation survey. If you can please fill that out, we will really appreciate your responses to that survey, as it will help us make any improvements as needed.
So it sounds like we don't have any questions, but if you do end up having any questions, feel free to reach out to us. I'll put our contact information up so that you feel free to reach out to myself or Fide if you have any questions as you're trying to think about your screening tools, or if you need help in your next steps. We are here for you if you need us. So thank you.
Yep, we're definitely going to be sending the slides to everybody via email.
Okay, thank you so much. I don't feel like we should hold you to this and maybe give you some time back in your day. I see we have an email address that we will make sure we get those slides to you. And I guess that's it. Thank you so much.
Thank you, everyone. Have a great rest of your day.